Millions of Americans are suffering with various forms of dementia, the most common being Alzheimer's disease, and a majority of those afflicted are cared for at home by family members. Caring for someone with dementia is difficult and can be overwhelming at times. Each day brings new challenges as the caregiver copes with changing levels of ability and new patterns of behavior. Nearly half of primary caregivers will themselves experience psychological distress, particularly depression. Good evening and welcome to Pennsylvania Inside Out Live. I'm Patty Satalia. We'll be looking at the care required for people suffering from dementia, primarily Alzheimer's disease, and we'll focus on the many challenges that confront family caregivers day in and day out, often for years. We'll also take your phone calls at 1-800-543-8242. Let's meet our guest. Stephen Zaret is a renowned clinical psychologist whose research has included the stress in family caregivers of dementia patients and on ways that stress can be relieved. His work has resulted in programs and services that assist family caregivers. Dr. Zaret is head of Penn State's Department of Human Development and Family Studies. Angela Taylor is an experienced caregiver who cares for a family member suffering from dementia. She's starting her third year as president of the board of the Lewy Body Dementia Association. Thank you both so much for joining us.
Thank you.
Dementia, which is the loss of mental functions such as thinking, memory, and reasoning, afflicts more than 5 million Americans. And as the baby boom population ages, that number is expected to increase. Dr. Zaret, what do we know about the causes of dementia?
Well, I think that there are many causes. You started off by saying Alzheimer's is the best known of the dementias, and it's important to recognize that there are several really as many as 60 different types of dementia. The most common, Alzheimer's disease, you mentioned Lewy body dementia, a group of diseases that get lumped together as vascular dementia, another group get lumped together as frontotemporal dementia. And within all of them, there may be multiple causes. The thing we call Alzheimer's disease may be a few distinct diseases that lead to a common pathology. And the result is that there may be many different causes. Now, there are a couple things that we do definitely know. One is it's not just aging. Dementia is a combination of some vulnerabilities that increase with age and something else that happens. And whether that's lifestyle, whether it's genetic susceptibilities, whether it's illness or head injury, there's a mix of these other things that seem to trigger dementia, and the mix may be different depending on the type of dementia.
What we do know, too, is that the course of dementia is usually a slow but relentless decline in mental and physical functioning. Who are the typical caregivers, and what's the spectrum of care that's required throughout the course of dementia?
Well, the typical caregivers are a husband or a wife. That's the person who's most likely to assume care. And about 50% of all caregivers to disabled elderly, not only those with dementia, are a husband or a wife. When there is no husband or wife, or if the spouse really isn't capable of doing it, then usually children step in. Often it's a daughter. If there's no daughter, sometimes it's a daughter-in-law. And increasingly we see sons who will do that, although they're still the minority. And then there's a group of people, and maybe as many as 15% or a little more than that, who aren't a close relative. In some cases, they may be close. Other relatives, it could be a sibling, it could be a niece or nephew, it could be a grandchild. And in a small number of cases, it's a friend, an old acquaintance, someone who isn't a blood relative.
And what's required of them throughout the course of a typical patient with dementia? Although typical probably is not a very good word to use here.
Well, there are some typical common patterns, but a great deal of individual variability. So, and what's required is really, it's a changing process. So one of the frustrating things that caregivers have always told me is that just when they get good at some part of the care, then they need to make a change and learn something different. So in the beginning, and we're identifying dementias earlier and earlier, it's little things, occasional memory lapses, maybe helping out with complex activities like managing finances, making sure the person remembers to do the things that keep them safe. But over time, those reminders become more and more, and the person's judgment begins to falter, so that they need more supervision, more reminders, more help getting things done. I think in the middle stages, where caregivers struggle the most, you have a situation where people with dementia can't initiate and sustain activities, and caregivers often are so overwhelmed with a lot of the details of care that they have difficulty keeping the person active and involved and engaged in meaningful ways, and that in itself causes other problems, restlessness, feelings of depression that the person with dementia experiences, and maybe difficulty sleeping because they're not active during the day, and so on.
So it sounds like learning new skills is part of this caregiving. Tell us, Angela, a little bit about your experience as a caregiver. I know you cared for your father. What were the circumstances that caused you to take on that responsibility?
Well, my father first had some surgery and had a very bad reaction to anesthesia and had a sudden drop-off in his cognitive functioning. And he wasn't able to follow the doctor's orders after the surgery, and I had to go travel 3 hours to where he was living, help him, and eventually realized that he was in a different stage of his life, one that we didn't expect him to be in so quickly.
And we're talking about someone who in his professional life was an engineer, who
Oh,
balanced lots of things.
He did. When my father started having problems with his computer, for instance, I became his tech support phone line, and he would call me regularly to ask for help on the computer. But it progressed beyond that to having problems managing larger projects. For instance, after his surgery, when it was time to sell the house, he wasn't able to manage dealing with the construction contractors. It was too many things to juggle at one time. And so we started with my helping him on some very tangible projects, but it slowly evolved into my more taking over those projects instead of being his assistant.
And in fact, you found out what kind of dementia your father suffered from doing some research of your own online.
I did. When he had his first appointment with his neurologist that I went to, which was the first time we were seeking a diagnosis for his cognitive decline, the doctor indicated that he thought my dad had mild cognitive impairment, but he also said he had a sleep disorder, which I had never heard about, REM behavior disorder. And so I went home and got on the internet and did my research and found out that mild cognitive impairment can lead to dementia. Well, when I started learning more about dementia and this REM behavior disorder, I found an overlap, and that was Lewy body dementia. And so when I found myself at the Lewy Body Dementia Association's website, I found a lot of symptoms that described my dad.
Now, I want to go back to you in just a moment ago, but I want to know about the stages of dementia. We talk about it often as early, middle, and late stage. Define each one for us, if you would.
Well, and again, they're really rough approximations, and there's a lot of individual variability. But early on, a person has memory problems, needs reminders, needs occasional assistance. As Angela was saying, she could help her father with projects, but he could still carry them out. As the dementia progresses, she had to take these things over herself. And at that point, there's a lot more management that goes on of daily routines, of making sure the person is supervised, safe, gets dressed in the morning. People may not feed themselves unless they're reminded. They may not do other kinds of care for themselves unless they're reminded. And they have a great deal of difficulty in the middle stages of keeping active and keeping involved. Late stage is when the dementia progresses to the point where there's fairly severe memory impairment. Persons have a great deal of difficulty sometimes with other cognitive functions, language particularly, so communication is still, it becomes very difficult. They'll need extensive help. They'll need to be dressed. They'll need to be bathed. They'll need to be sometimes helped from chair to standing, or from bed to standing, and so on.
Do most people at a certain stage recognize that they have some form of dementia? And then I want to find out if your father did or does.
Oh, that's a tough one. Early, many people recognize it, but not everybody. And as the disease progresses, if you ask patients, you know, how's your memory? How are you doing? They'll often say, no, I don't have any problem. I'm doing okay. But every once in a while, there's an awareness. It may be something that's very general. It may be, I know something's wrong with me. What's wrong with me? And then it won't be there later. And then there are occasional people who far into the middle stages will say, I have Alzheimer's disease. I have some other kind of dementia. I have trouble forgetting. So it's quite variable.
Does your father know he has Lewy body dementia?
He does, although he frequently doesn't remember what it's called. Dad knew that he was having problems with his memory, and it took a long time, however, even though he admitted that he was having problems, for him to seek treatment. And that was one of the things that I was adamant about, was that we were going to see the neurologist because he was going through changes that were not typical for him any longer. And when we finally crossed that line, then he was much more willing to know what was going on with him. But there was a time of denial. It really was.
You know, Patty, what Angela just said was really a key to diagnosis. Her father was going through changes that weren't typical of him any longer. And with aging, with normal aging, there's a continuity. We are ourselves. The changes are really mild and subtle. But then there's something different that goes on when a person begins to suffer from dementia.
Can you talk a little bit, Angela, about the skills that you've had to acquire over your father's, the progression of his disease? I know he lived in your home for a year, and he's now living in an assisted living situation.
Well, I can't say that there are specific tangible skills, but I certainly took on a lot of tasks that I would not have normally taken on for my father. For instance, he had always been a very private man about finances and whatnot. It quickly got to the point that he wasn't able to balance his checkbook. And my father wasn't willing to relinquish control of his finances, but he sure needed some help. So I stepped in and got involved directly, helping him manage his finances, making sure I became his social secretary and his medical secretary and his legal and financial secretary. So we actually became probably a lot closer over the course of the last 5 years than we were before, and we were very close before. But that barrier between parent-child started to blur. And at this stage, it really has made a complete transformation, where I do most of the decision-making for him, but I consult with him heavily on those decisions, and I try to do things for him that are in his spirit. So financial matters, medical matters, we have had to negotiate and find a balance between his style and his needs, and sometimes they haven't always matched up.
What was the tipping point? When did you realize this is beyond my ability at home?
Oh, I have 2 young children. Now they're 9 and 11, but at the time they were 5 and 7, thereabouts. And so they were young, and they had a lot of needs, and they were used to mom being home full time and, you know, available to them. And when my father came and lived with us, he was dealing with both a physical problem, because he had the surgery and he had some pain issues, but he was also going through a lot of cognitive change. And they had needs that didn't always, well, they had needs that frequently coincided at the same time. And so we worked it out. You know, we were very honest with Dad, and I said, I love you. I want to be your daughter. I want to love you and support you and keep your life at the quality that I can as your daughter, but I'm not a nurse, I'm not a doctor, and I don't know what all of your needs are. And so when we talked about his long-term needs and how they were going to become progressively more difficult, he didn't want to see us going through a burdensome situation. He was absolutely adamant about that. And so we looked for a long-term solution that would work.
And he was part of that decision?
Absolutely. We did this early on in his decline. We didn't want to wait until it was too far for Dad to participate in it. Okay.
If you have questions about caregiving for a patient with dementia, a family member, our telephone number is 1-800-543-8242. Now, Angela brought something up a moment ago. You mentioned the word transition, and you've done a lot of work. A research project of yours, the NONA project, explores the transition from independence to dependence. Tell us something about what you've learned.
Well, actually, some other work is really more directly relevant, which is doing what Angela did with her father in a more in a systematic way with a sample of people who, like her father, could still talk about their situation and think about it. And we found the same thing, that time after time, when you involve both people, the primary caregiver and the person with the disease, and had them talk about the future, they could come to an agreement. And it was really marvelous to see this happening. It's the thing that many families either don't get the opportunity to do because diagnosis isn't made early enough, or they're afraid to do it. But we didn't, in the series of participants who were in that research, we didn't have anybody who got up and walked out and said, I don't want to hear about this, there's nothing wrong with me. They all engaged in a discussion and said, if this happens to me, it would be okay if you do this.
Now, this responsibility that fell to Angela more commonly, although adult children, mostly girls, take this on, but it more commonly falls to a spouse. The stresses for a spouse are different than the stresses for a daughter or a sibling or close relative. Talk about that if you would.
Oh, there are a host of things that are different. The spouse is himself or herself older, and so that means that they may be struggling with their own aging in one way or another. The relationship is more personal, closer, that often losing the person they've depended on most for emotional support, for help and assistance. And I think the pain in that loss is often greater than, and I don't mean this, you know, everybody feels the loss, but in some way it's more intense when it's a spouse.
Tell us, if you would, where people in that situation can turn for help.
There are a lot of different places. There are, a starting point, as Angela did, is to find out as much as you can online or from information sources about the type of disease that your relative has, and those sources, websites, the area agencies on aging in Pennsylvania, other nonprofit organizations will have an array of services that they'll be recommending. Support groups are a good way of getting a lot of information about what's available in your community. There will be from time to time educational programs that are offered about different types of dementia or about managing the problems of dementia. And I think one of the most important things is to learn about the services that are available and the alternatives for care, just like Angela did, of looking into the types of long-term solutions there are. Every family needs to do that, and to do it as early as possible. It may be that they don't decide to make a change in the living situation for months or years, but they need to know what their alternatives are so that if they have to make a change, they're well prepared.
It sounds like have this discussion before anyone is unwell.
Oh, yeah.
Is the way to do this. You know, lots of people talk about changes in personality and behavior as one of the most difficult things to deal with. There might be agitation or paranoia. There may even be hallucinations among some people suffering from dementia. What's the best way to deal with this kind of behavior on an ongoing basis, because these kinds of personality and behavior changes can be different from day to day?
I'd say get help when they first start to occur. There are specific skills that we've taught caregivers in our research projects that do seem to work, that help them manage these problems.
Give me a concrete example.
These problems come about because of the disease, but because of specific triggers in the environment. And so we teach caregivers to look for those triggers. And let's say the trigger for not sleeping at night is sleeping during the afternoon. When you look at it that way, there's an easy solution, and that solution is to increase activities in the afternoon to provide something that's stimulating, and that will help improve sleep at night.
Finding something that's stimulated may also be a challenge.
Well, yes, and for some caregivers, they can work this into a routine, and they can begin to develop more activities. There's some research now out of University of Washington that shows that caregivers can implement daily regimens of exercise for their relative. And that's very helpful in doing things like improving sleep and decreasing other behavior problems. But some caregivers can't do that, and that's when they need to either bring in help or turn to a program like an adult day service program that will provide therapeutic activities during the day, and that will keep a person with dementia engaged and involved in a pleasant social situation.
You mentioned exercise, and exercise can be as powerful a tool in dealing with dementia as many of the drugs that are available, in fact even more effective. And of course we know that what's good for the heart is good for the brain.
Oh, absolutely. The research on exercise suggests there is probably more and sustained gain than with the drugs that are currently available. And you know, I wish there were more powerful tools, but exercise certainly is one of the optimal ones and has virtually no side effects.
What's happening with your father in terms of keeping him engaged and active during the day?
Well, Dad participates in different activities at the assisted living residence where he lives, and he exercises 5 times a week. He uses weights twice a week, and he does stretching 3 times a week. And I've noticed the days that he exercises, he is mentally more clear. His energy is better, his speaking is better. Now, he can get overtaxed as well, but keeping him engaged in activity, especially physical activity that's not too stressful, has been really helpful to him. When he comes over to our house, we may go out and shoot some basketball, you know, and that's something that he's enjoyed. So, you know, we always find something to do.
Your father comes to the house every Sunday for dinner.
Every Sunday, that's right.
And he asks you, because it's still important for him to be a contributing member of this family, what can he do to help? How
Absolutely.
do you answer that?
Well, he dries dishes every Sunday night. But he likes to go out and shop. If we're going to have a special meal, he likes to help plan the meal and go shopping for the meal. And so he always has stayed connected to the activities that we're doing. He likes to stay active, and it's been challenging sometimes to find things that both engage our family and engage my dad. We find that music and sports and things that he can observe passively that don't tire him out are a really good balance for everybody.
No, you mentioned music, and we talked about this before, Dr. Zaret.
Yeah.
There seems to be growing evidence that musical memory is spared in some dementia patients. We don't know, I guess, whether it's because music has some special place or whether this is an overlearned skill, unlike other cognitive skills. Knowing what we do, the little that we do know about music, what role might it play in households where there's someone suffering dementia or in assisted living situations or nursing homes?
Well, I think very much like Angela was saying, it can be part of a daily routine. There can be periods when there's music, and it needs to be the music that this person enjoys. You can walk into some nursing homes and the staff is playing their music, and that's not the thing. Or putting, you know, and it could also involve performance, singing familiar songs and other things. I think one of the keys of dementia care is to find things that the person can still do, parts of the person that are spared by the disease. So it could be music. Another thing that's often spared is physical habits, the ability to play a sport, to play golf or to play tennis or to do other things. And you want to capitalize on that and do it as much as you can.
Social skills seem also often to be spared.
Yeah, in some people they are. And there was a nice program I saw once in Scotland where ordinary people ran a daycare program out of their homes, and people with dementia would come mid-morning. They'd sit down, they'd have a cup of tea. You know, the English are great with their social rituals, and the Scots are great with their social rituals, and everybody kind of fell into a familiar routine and could maintain a very nice conversation.
The interesting thing about the musical memory is that someone who can't remember their child or their spouse's name may be able to sing seamlessly the lyrics to an entire song.
Yeah, and that's one of the, again, we want to capitalize that, but it's also one of those things that can bewilder families, and they say, well, why can he do this but not that? And they sometimes think it's willful, and it's really not. It's just part of the disease. Some parts of the brain are spared, and we want to build on that. As far as not knowing, I think they always know these people, but they may not be able to name them, and there's still an emotional tie, and they'll respond to that.
But many people report that when music is being played and a family member can sing along, their frustration level is down, that perhaps their communication with a caregiver in a nursing home situation has improved. What's your experience, Angela, with music? I know you come from a musical background.
I do, but you know, I see music not just from the dementia side, but from my background as a musician. I think it's a universal language that reaches people beyond a mental level. It touches people emotionally, and those emotions that doesn't fade away. You know, my father's insight into who he is and his ability to interrelate with people is very strong. He can't do all of the things that he used to do. Although with Lewy body dementia, there's an element of fluctuating cognition, so I can't predict what days he can do some things and not do some things. But I think that music really touches a part of us that is non-cognitive. Does
your father feel a loss? You said there are times when he doesn't even know the name of the disease that he suffers from. Are there days where he's frustrated and he can feel the loss, you know, the loss of cognition that's slipping away from him?
He's a fairly stoic guy, so he doesn't talk about that a lot. I see that he gets frustrated. He's so used to being able to solve problems, and in Lewy body dementia, the executive functioning is really impaired. And that was one of the things that I saw earliest with him, is here's a man who could fix and build anything and could no longer connect the cable to the back of the VCR and the television so that they could all interact appropriately. So, yeah, he gets frustrated, but I think that his personality type has taken it in stride because he's not, in general, a negative person. I think no matter what obstacle he would have faced in his life, he would have found a way to work within it.
Now, she's talking about a situation where her father's personality, the general characteristics of his personality have stayed intact, and there are some people who are dealing with a personality they do not recognize. That seems more challenging.
That certainly is more challenging, yes. And it's very easy in that situation for the family members to take it personally, and that complicates the situation. They need to understand that this person in front of them is still the individual they love, and that part of that is still there.
Okay, we have a question that's coming in, and we'll get that in just a moment. But before we get that question, we are celebrating basically the 100th anniversary of the diagnostic label of Alzheimer's disease. And it's interesting that at this time, at this benchmark, there are lots of people who are saying that maybe the label is not so good an idea, that it causes fear and pain and harm in some patients. I'm wondering what your take is on that.
It certainly does. It's a scary diagnosis, just like cancer is a scary diagnosis. But I think we need the labels because they're helping us identify what these diseases are, and they're generating interest in supporting research to uncover some of the possible causes.
And if I can echo that, I agree that the names, while they don't sound pleasant and they have a fear component to them, they're just names. One of the things that I find important to my dad is that we know he has Lewy body dementia. Dementia is as ugly a word as Alzheimer's is. It strikes the same fear. But we're learning to live with it and not die from it. And that's a really important philosophy for us, is that we don't want it to become the main identifying factor of his life.
It would seem to me then that there's sort of been a sea change in her attitude about dementia as there has been about cancer, because one of Kevorkian's very first assisted suicides was for someone who got the diagnosis of Alzheimer's disease and was absolutely panic-stricken by it.
Oh yeah, yeah, and that was a tragic situation. So I do think it's important that diagnosis, especially when it's made early, be handled in a sensitive way with appropriate follow-up. And unfortunately, that only happens some of the time.
Okay, our telephone number is 1-800-543-8242. We may be experiencing phone problems, I'm not sure, but we got a call in earlier from John E. from Williamsburg, who is asking about the use of antidepressants and other nutraceuticals in combating dementia. And food. I mean, are there certain foods or diet maybe that play a role?
Well, let me start with antidepressants. Antidepressants sometimes can play a role in helping reduce some of the troublesome symptoms. Patients with dementia can also be depressed, and treating that depression with a medication or with behavioral therapy can be effective and can help the patient and the family function better. As far as foods, the main thing is to maintain adequate nutrition. There isn't anything that's been found to be helpful more, above and beyond maintaining good nutrition. Now, sometimes that's a challenge because people become fussier eaters or they skip meals and the family may not know it. And there is a risk of malnutrition. And there is a tendency, at least in some dementias, in Alzheimer's, for instance, for nutrients not to get absorbed efficiently. And so it's important to make sure the person has enough of an intake and a balanced nutrition or supplements.
And there does become a point where eating and swallowing are things that people don't automatically know how to do.
Right, right, and that's a very challenging period of care.
Angela, talk a little bit about providing situations and environments where you don't need to say no or correct your father if he says something wrong or his memory has failed him. That seems to be an important thing in reducing the frustration and keeping the connection going.
It is. There are some things my father has learned he's no longer good at. For instance, public speaking. He gets very tongue-tied if there's a situation where he needs to address a group of people. And so when we have gone to events like, say, a reunion or whatnot, if there's something to say to more than one or two folks, I may say that for him. But he has a great sense of adventure, and so he's willing to go out and try a lot of things, even if he may not be able to do them the way he used to. So we just try to keep things varied for Dad.
Are there some tips for reducing the no's and correcting someone who's having, no, that's not the right way to get dressed, or no, that's not right, she's not your sister, she's your neighbor? Oh
yeah, you want to try to avoid them as much as possible and guide the person and work your way around it. One thing is, a lot of the things that we do in everyday life where we assume the facts need to be correct, well, they don't have to be correct. So you can let a lot of things go. If a person with dementia calls you by a different name, that's okay. They're reaching out to you anyway, and it's a minor mistake. It doesn't need to be a big problem.
There's some really interesting work going on at the Wisconsin University. Ann Basting's doing something called time slips. And instead of asking someone with dementia to recall stories from their past, she's helping them make up new stories using a photograph, a provocative photograph of something, and allowing a group of people with dementia to add one, a portion to the story. And it really seems to be doing incredible things in getting people to feel needed and alive and still engaged in things.
Oh yeah, I mean, it seems like a very interesting project. There are a lot of, I think what it's doing is, as Angela was talking about before, it's recognizing that people still have emotions, they still have ideas, and it's giving them a way to get around those memory blocks and get these things out. I've talked with an English poet, John Killick, who talks with people with dementia and writes down their words, and these it's poetry. It's just there are gaps that in everyday speech we'd say, oh, this person isn't making sense, but you write them out the way Killick does.
And it is poetry. I've read some of these stories. They are amazing. So it's something that people at home can do, people in centers can do. Tell us how you chose, by the way, Lindsay, the assisted living facility that you chose for your father.
Well, we visited all of the long-term care facilities in the area, and we wanted to make sure that we found one that had multiple levels of care, that it wasn't just a standalone assisted living, because we knew his needs were going to progress. We looked for some place that was going to have a protective environment, that in case he became at risk for wandering, that he would have a comfortable place to be that was still protected. But we also didn't want something that wasn't going to allow him to engage at this stage of his life with people who were still cognitively whole. And so this assisted living residence where he is now has, independent living, assisted living, a dementia care unit, and their skilled care. And so for us, that was very important.
Resources, I don't think, were a big issue. Your father had the resources to provide the care, to purchase the care he needed. What happens to people who don't?
Well, in some ways, it's the people in the middle who get caught the hardest. People who don't, their relative can qualify for medical assistance, and that will pay for long-term care. Now, often the choices are limited, and fortunately, in many Pennsylvania counties, there is a county nursing home that provides a good quality of care, and will do a good job of it. People who are well off have the resources to do it. People in the middle often are the ones who they can't quite make it with paying for care, but it's going to take a while until their relative will qualify for care under medical assistance. And
is there a phone call they can make somewhere to find out, what do I need to do to qualify?
Yeah, absolutely. That's one of the things the area agencies on aging in Pennsylvania and other states will do.
We don't hear much good about VA hospitals these days, but I know of some people who are receiving assistance for dementia, for a spouse with dementia, because they did serve overseas. And so in some communities, it's the VA that's providing help to families.
Oh, yeah, absolutely. And in some cases, the VA steps in and will take the most difficult cases, because the people who, because of the type of dementia they have a lot more behavioral problems, can't be managed in a community nursing home. The VA becomes the place of last resort, and the VA is working hard to improve their programs.
Okay. We have a phone call. Our telephone number is 1-800-543-8242, and we go to Cody from Oswego. Go ahead, please, Cody.
Yes. My father, he was diagnosed with Alzheimer's probably 2 years back. And it's hard for my mom and I to connect with him about past memories. And I was just wondering if there's anything we can do to help him remember, going through photographs or something like that.
Yeah, that's interesting. Dr. Zera, you handle that first, and then Angela.
Yeah, I don't know that there's any one thing that you can do to help him remember, but certainly reminiscing, and if he enjoys that, looking at old photographs, as you said, talking about things that happened in the past would be good things to do. And sometimes you just have to find what he enjoys and go with that, and that can be most helpful.
Do you pull out the photo album, Angela?
Not so much the photo album, but one of the things that we have done is just to talk about stories from my childhood and talk about his childhood and anything in between, because we have found that his long-term memory was more intact than his ability to do things today. And so just kind of interviewing him in amusing stories, in tell me about your old high school, what do you remember about that? That has been really helpful.
Any do's and don'ts?
Not from our side.
Okay, we go to Sherry, who is calling us from Phillipsburg. Go ahead, please, Sherry.
Hi, I'm 53 years old, and I just turned 53, and I was actually to Pittsburgh today and was diagnosed with Alzheimer's disease. And I guess my question to you is how does that expedite in someone that is younger as opposed to someone that is older and at the beginning stages, middle stages, and ending stages? How does that...
What prompted you?
What am I looking forward to here?
Okay. I'm curious, before we answer that question, before our guests answer that question, what prompted you to make that trip to Pittsburgh in the first place?
What prompted that was probably 2 years ago. I was just having kind of, just memory things that someone else may not, like family members may not pinpoint as being odd, but I certainly did. And I just went to my family physician for, a period of, a year, telling him that I just was really having trouble making recall, and I was doing silly things like, directions were very poor, or getting lost in some place that I was very familiar with, that kind of thing. And so I've been going back and forth to Pittsburgh, and this was my last visit there, and I've been going for 6 months, and today was the final visit for them to take all their information that they have used to evaluate what is going on. The last thing I had done was, I believe it was called a PET scan, and they, gave me that, took all that wealth of information, and that was their conclusion, and that is what, took me there. My doctor, actually a neurologist, made the, planning for me to go there and have the testing done.
We talked about that label. What was it like? Was it some measure of comfort to know that there was a name for what you've been experiencing?
No. No, it was, I must say I was pretty well sure that that's what it was when I got there, so I wasn't in, and they said that to me because I didn't have a great reaction, and I did not have a great reaction, and I probably haven't had one yet here, but I was pretty sure that that's what it had to be because nothing else fit, nothing else, seemed to be, they did, my vitamin B12 was low, and I just heard you say in there that that's another thing with people, that they don't absorb things as well as, someone else might, nutrition-wise, into their system. And so that was, so, that's another thing that's part of it. I have to take vitamin B12 shots for a series of, I think, 4 weeks, and then after that I can just take the pill. And that should, make it, it should work well then.
And I can hear that there are young children in the background at Sherry's house. Dr. Zara, what can you say to someone who at 53, this is early onset Alzheimer's?
Yes, it's an early onset Alzheimer's. The course for each individual can be a little bit different. So one of the things that people with Alzheimer's have said over the years is, I take each day at a time. One of the things is you obviously have a sense that this is a progressive disorder, and it's important to begin thinking about and talking with the people closest to you about how you want things to be handled when you can't do everything yourself, and to do things in a way that in the long run you'll be most comfortable with.
Anything to add to that, Angela?
Well, I just want to commend you for going and getting treatment and seeking it. I'm assuming because you went to Pittsburgh, you went to a specialty clinic.
Yes, I did. It's a memory
Excellent.
clinic.
That's one of the most important things that we tell families who are seeking a diagnosis, is going for a diagnosis that specifies what kind of dementia that you have or maybe developing is very important, so that you can be prepared, your family can be prepared, you know what symptoms you're going to face and what treatments you may need. And I think knowledge is power, and so I just commend you on going and getting that information now instead of kind of brushing it under the rug.
And the early stage Alzheimer can be quite long.
Oh yeah, yeah. It
Years, many years.
Mm-hmm. Yes, that's right.
Okay. All right, thank you so much for your call, and best of luck to you. We go to Doris, who is calling us from Altoona, Pennsylvania. Go ahead, please, Doris.
Yes, my mother was diagnosed with Alzheimer's, and it's sort of in a catch-22 situation now where she is medicated because of violent outbreaks, and when she is medicated, she has a problem walking, which causes falls. She has just recently fell and broken her nose and bruised her face and all kinds of things like that are hard to see, but I fault no one because I know they are one-on-one when they need to be, and they're just wonderful with her, but they just don't know what to do anymore. So she is now in a facility where they are trying to monitor her medication and get it correct, but they're having trouble, and they are going to return her back to the nursing facility here shortly. And I'm just afraid that she'll just be caught in the yo-yo effect of medicine and falls and violent outbreaks. And is there any kind of a help for a situation like that?
Dr. Zaret?
Well, you're describing something that I think is a very typical part of care and one of the dilemmas that families face. And without knowing a lot about your mother's situation, I really can't comment about the details. What's familiar about it is the kind of vicious cycle of the medications which are needed to control behavior, which then cause other problems. We obviously need more tools to help people with this condition, help staffs manage the behaviors better in ways that'll reduce the outbursts. But I don't know that there's a simple solution. You've probably taken the right step to get her out of that environment and evaluated to see if something can make a difference, and continue working with the staff there to see if they can come up with something, or if they can bring in a consultant to help them manage the behavior.
One of your current projects, Dr. Zaret, is adaptive interventions for at-risk caregivers. What risks do caregivers of people with dementia face? What are the most common ones, and how can we prevent them?
I think, well, there are a whole host. That's why we talked about it as adaptive intervention, because rather than saying there's one kind of caregiver stress, we're talking about a lot of different stresses. So for some caregivers, and the last caller is an example of this, it's the behavior problems which occupy all the time and effort. For others, it may be that it's a feeling of loss, a feeling that I'm losing this person, I'm losing this relationship. For others, the care spills over into other areas of life. It may, Angela talked about this earlier, it was affecting the things she could do with her children. It may affect people's ability to go to work every day. It may affect their financial situation. So what we try to do is identify which specific stressors this caregiver is experiencing, and then tailor the treatment to them. That's what's adaptive about the intervention.
Our telephone number is 1-800-543-8242. This is Pennsylvania Inside Out Live, and I'm Patty Satalia with guest Dr. Stephen Zaret. He's head of Penn State's Department of Human Development and Family Studies, and Angela Taylor, who is an experienced caregiver and the president of the board of the Lewy Body Dementia Association. We have a caller now from Katanning. Lois, you're on the air. Go ahead, please.
What is the phone number and location of the Dementia Clinic in Pittsburgh?
I don't know that. That's something we can put on our website for tomorrow. Do you happen to know it?
I think that there are programs that are very good both at University of Pittsburgh hospitals and at Allegheny General Hospital. I've known people who've used both with good success.
Okay, and a quick way that she could find that number. You said which two hospitals?
At University of Pittsburgh.
University of Pittsburgh.
And then at Allegheny General.
Okay, Allegheny General.
All right, thank you.
Thank you for your call. We go to Janice, who's calling us from Altoona, Pennsylvania. Go ahead, please, Janice.
Hello, how are you tonight?
Fine, thanks.
I have two questions about Alzheimer's. And the first one is, what testing do they use and how do they interpret it?
Good question.
There's a wide range of tests that are used. There should be a general overall physical to see if there's some other problem that may be causing memory symptoms. There's usually some type of a brain scan. The caller earlier mentioned a PET scan, which is available only in a few centers. Most people will get an MRI scan. And again, that's often to rule out other problems besides Alzheimer's or other dementias that may be causing memory loss. And then usually a complete workup will include neuropsychological testing to determine what types of cognitive problems are present. There's no one sign or symptom that always says this is dementia. What the diagnostician does is puts together all the evidence and looks at the overall pattern, and then can make a reasonably accurate diagnosis of whether it's dementia, that is, are these problems worse than you see in normal aging, and the type of dementia.
Now, some people may be confused, and I won't hang on because I know you have a second question, but our earlier caller said she was positively diagnosed with Alzheimer's disease, and we'd always heard in the past that that can't be done until autopsy. But we are now saying with pretty good reliability that we can find that out long before that.
Yes, an experienced and well-trained clinician can make a definitive diagnosis of type of dementia without an autopsy, and will be 90–95% accurate.
Okay. Janice, what's the other part of your question?
Oh, the other one, thank you very, very much, is it's kind of twofold. Can it be genetic or environmental caused? And what effect and how do antidepressants contribute to the disease or the cure?
Okay. With Alzheimer's, we know the most about the genetics. There are forms of Alzheimer's that are genetically determined. These are rare, and they usually are the types of Alzheimer's that occur earlier in life. Later in life, Alzheimer's and the other dementias may have what are called susceptibility genes that increase the risk of the disease but don't cause them. So there needs to be a genetic, there's a genetic role, but there needs to be an environmental trigger that causes the disease to begin.
Which explains why a sister may have it. You know, siblings,
yeah.
One has it and one doesn't.
Well, and even in some studies that
Twins.
I'm familiar with, twins, identical twins, one has it and the other doesn't. So identical twins, if one gets it, even later in life, there's an increased risk, but there can still be discordance.
Okay, and how about the antidepressant part of this?
There's no evidence that antidepressants play a role in causing Alzheimer's disease or another type of dementia. What you sometimes see, though, is that before anybody notices any kind of memory impairment, there's an increased risk of depression. And so the sequence may be the person is depressed, gets treatment for depression, and then people begin noticing the dementia. There really doesn't seem to be, though, any link between that, except that some of the same changes that are going on in the brain that eventually lead to dementia may also be causing depression.
Okay, but actually antidepressants can actually be helpful for some dementia patients in helping them get through daily living.
That's right, and with not only with depression, but sometimes with anxiety and worries and other problems.
Okay, we go to Martha, who's calling from Port Allegheny. Go ahead, please, Martha.
Yes. Would someone speak about the difference between Alzheimer's dementia, or dementia generally, and delirium? And are those conditions mistaken for one another?
That's an excellent question. First, you know, the term dementia is a general term that covers a lot of different diseases, with Alzheimer's and Lewy body being two types of dementia. But there's also something called delirium, and delirium is very important because it gets mistaken for dementia time after time after time. Like dementia, there can be some memory impairment, but there are differences. It comes on suddenly. It usually has an acute trigger like a new medication or a head injury or the effects of anesthesia during a surgery, and most of the time the delirium will resolve quickly, especially if the cause is identified. But all too often it gets mistaken. We look at it too quickly. People aren't aware of the difference between dementia and delirium. They see mental changes and they assume because this person is older it must be dementia.
All right, thank you for your phone call. I don't think we have time to take any more. But you know, elderly people increasingly live in an age-segregated world, and I read a sociologist's work from the University of Michigan, and he says that isolation is as deadly to elderly people as smoking.
Yeah, that's a very nice way to put it. I think one of the most important things as we grow older is staying involved, having something that gives meaning to our lives. One of my colleagues talks about mattering, having an involvement that you feel makes a difference, and all of that leads to a better quality of life.
Angela, if you had one piece of advice for someone who is the caregiver for a family member with dementia, what would it be?
Learn how to ask for help early. Don't wait until you're already at crisis stage to ask for help, because you won't know where to turn.
All right. And if you could change one thing or one practice that caregivers do, what would it be?
Angela said the right thing.
Okay.
Get that help early. Do it now. Don't wait for a crisis.
Now, you've been at this for decades, working on caregiving issues. Have you noticed any improvement in the treatment of dementia in those several decades that you've been at this?
Sure, there's a lot more information available. There's a lot more knowledge about what caregivers can do to make a difference. And we have empirical evidence, just like we have evidence that this drug works for this disease. We now have evidence that these strategies work for caregivers and will help them manage the stresses that they're experiencing. So we need to help now connect caregivers to that information about what works.
All right. Thank you both so much for being with us. Our guests tonight have been Dr. Stephen Zaret. He's head of Penn State's Department of Human Development and Family Studies, and Angela Taylor, who is an experienced caregiver and the head of the Lewy Body Dementia Board. For Pennsylvania Inside Out Live, I'm Patty Satalia. Thanks so much for watching.
A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.